our board's web page. This meeting will be streamed live, and of course, you can go back and watch it on the archives. We have staff have prepared a full agenda, and that is a product and a thanks to many of the subcommittees who have been a part of formulating topics on our sort of three areas of focus of the cost board for this year. And so I am officially going to call this meeting to order. And a couple of housekeeping items. We were scheduled to have the nominating committee of the cost board that is to be on Thursday, June the 4th. The board has received one nomination at this particular time, so the nomination committee is actually going to cancel that meeting in lieu of sort of the amount of content to cover, and they'll find another time in the convening months when there are additional nominations for particular seats to fill. And as I mentioned, for today's meeting, there's really the opportunity to sort of focus on the three areas that we have been talking about for the cost board's priorities for 2026. That first priority area is on market oversight. The second is on primary care. And the third is the healthcare spending growth. And so we've got presentations teed up for both of those. In January, we spent a fair amount of time on market oversight. On March, we began to talk more in depth about primary care and got a little bit of deeper exploration related to that subject. And so this particular meeting brings together those first two topics in a very intentional way. So we're going to spend a lot of time talking about primary care. And in addition to that, we'll talk about not only just investment to primary care, but access opportunities, workforce challenges, and consolidation trends within that particular market around things that influence affordability and overall healthcare costs in the state. That subject and that meeting will be covered by Dr. Zerzan Thul, who will be joining us as HCA's Chief Medical Officer. She serves as chair of the Primary Care Advisory Committee. Then we have some guests with us as part of our agenda. Kevin Grumbach, who serves as professor at UCSF, the Department of Family and Community Medicine. And Dr. Grumbach is going to be here talking about some modeling efforts that have taken place in the literature around increasing primary care investment, while also with an eye towards controlling healthcare costs. And then we are going to hear from Harrison Fontaine from our staff that will talk about the cost driver data presentation. We will take a 10-minute break as a board, and then we will move from a presentation from the Washington Health Alliance on their annual quality report. And then finally, we will leave time facilitated by staff for discussion on healthcare consolidation and implications for primary care affordability, bringing those first two subject area to topics together, if you will. So thank you all so much for being here. And as the overview of that, with that, I am going to turn to Ross to do a formal roll call to ensure that we have quorum before we dive into the review of the March meeting minutes.
Thank you so much, Director Moran. Again, for the record, my name is Ross Valori, Board and Commission Director here at HCA. And I'll turn to roll call now. Director Moran.
Here.
Thank you. Jane Beyer. Thank you. Emily Bryce.
Present.
Thank you. Eileen Cody.
Here.
See Eileen, she's looking for her button.
I see your mouth moving, and I see you, Eileen. I think that's sufficient.
We'll entrust you'll be able to come off mute at some point.
Thank you. Lois Cook. And Lois let us know that she would likely not make it today. Ken Gardner. Ken Gardner. Marking Ken Gardner as absent. Hart Hodges.
Here.
Thank you, Hart. Leah Hole Marshall.
I see Leah, yeah.
Yeah, and just a quick note while Leah is unmuting, Leah will be the delegate for the Washington Health Benefit Exchange.
Here and
There's Leah.
present.
Yeah, thank you, Leah. And last but not least, Kim Wallace.
Yeah, here. Good afternoon.
Thank you so much, Kim. We have a quorum for today, and I will hand it back to Ryan for review of the March meeting minutes.
Okay, excellent. We are going to do a review and approval of the minutes. So the last meeting that we had was on March the 25th. That is on tab 2 for board members who are looking at that as part of your package. As noted previously, all of our materials, including the recordings, are also posted on the webpage for the public's reference so that they're able to view that as well. And tab 2 for board members. Are there any discussion on the March 25th, 2026 meeting minutes? Hearing no discussion, is there a motion in favor of the March 25th, 2026 meeting minutes? Motion on the table. Is there a second?
Second.
All in favor of approval of the March 25th, 2026 meeting minutes, say aye.
Aye. Aye.
Any opposed? Hearing no opposition, the minutes for March 25th, 2026 are approved. We will now move into the portion of the public comment section. Again, we take public comment as part of an open public meeting very seriously. It's an important part of the process and the cost board's work. Board members listen intently in terms of the comments that are brought forward to members of the public, whether impacting industry or individuals, around the affordability and cost challenges that are facing communities across our state. So to help facilitate public comment, I will turn it back to Ross. Thank you, Ross.
Thank you so much, Director Moran. Any written comments that we receive are included in each meeting's meeting packet, and those would be found under tab 3. We did not receive any written comment in advance of this meeting, but as Director Moran noted, that circulated to all board members in advance, and they review that and take that into consideration while preparing for these meetings. So now I'll turn to any folks that want to provide verbal comment. You can raise your hand and our staff will unmute you, and you can turn on your camera as well. Please note, sometimes that takes 1 minute for it to switch over to allow you to become a panelist. So if you're having some difficulty, normally if you just wait a moment, you'll be able to turn on your camera and turn on your microphone. We'll also be having a 2-minute speaking limit today, so you'll notice the timer at the top of the screen. If you could kindly keep your comments within that period, it would be greatly appreciated. So now I'll turn to hands raised, and I believe I see Katerina LaMarche. Please go ahead and unmute yourself.
Hi, yeah, thank you. I'm Katerina LaMarche, Policy Director with the Washington State Hospital Association. I noticed that a theme across today's presentation seems to be the connection or relationship between primary care investment, outpatient cost growth, and system performance. The question we have, though, is whether the board is looking at primary care as a standalone spend category or as part of the infrastructure of the broader delivery system. Because in the first analysis, we noted there's a concern that Washington is underinvesting in primary care, but the second analysis shows that hospital outpatient care is one of the main cost drivers. So it would be helpful to understand how much of that outpatient spend is on primary care and how that's grown over time. Similarly, the WHA analysis seems to show variation across clinics, including some top-performing hospital clinics, but it's only done on large clinics. So it would be helpful to see an analysis of small and independent practices and how their aggregate performance compares. Also notice the national data appears to show that hospital and primary care has higher costs, but those higher costs may come with benefits like better care coordination, team-based care, technology investment, and preserving access in underserved areas. So here it would be helpful to understand if our outpatient cost growth reflects those deliberate investments in more coordinated primary care infrastructure and, how that ends up helping long-term affordability and access and not just reflective of higher costs. So overall, we recognize claims data is an important tool, but it really only provides one lens. So we hope that the board also considers the underlying infrastructure, access responsibilities, patient complexity, and sort of like the downstream outcomes that help shape those claims, particularly when we're looking at investments in primary care. Thank you.
Thank you very much, Kat. Appreciate that. Now we'll turn to Jeb Shepard. Please go ahead, Jeb.
Thank you, Ross. Good afternoon, Chair Moran, members of the board. My name is Jeb Shepard, Director of Policy at the Washington State Medical Association. Wanted to be on the record thanking you all for studying the issue of market consolidation, especially as it impacts affordability of primary care. The State Medical Association has strong policy in support of bolstering our primary care system in order to get more folks treated for chronic conditions and preventative care, keep folks out of higher cost settings. We've been members of the board's advisory committee since its inception. We continue to support studying the reasons for ongoing increases in the cost of healthcare in our state. And our ask here around this particular issue is we'd like to reiterate that you continue to explore the upstream reasons for consolidation, those being their underlying cost drivers that lead to some of the consolidation. Drivers within the state's control, just a couple examples. Independent physician practices have seen a 40% increase in the state's business and occupation tax since 2019, so just over 7 years. Medicaid rates do not cover the cost of delivering care, and we haven't seen a meaningful increase in years, if not decades, to those rates. And we'd appreciate, as this board has done in the past, a continued focus on the level of administrative burden that drives costs for physician practices. It's more and more difficult to keep an independent practice open these days. These are settings that are embedded in communities where patients can access affordable, high-quality primary care, chronic care management, and as I noted, keeping them out of those higher cost settings. In the current environment, we've seen this over the last 20 years, and unfortunately, it's only poised to get worse. Some practices in this environment find themselves in a position with very few choices when they can't make the math work. And the two choices that some may be faced with is to close their practice, and that's a huge loss for a community when they lose a physician practice, or sell to a larger organization. So thank you for keeping those thoughts in mind as you consider this issue, and thank you.
Thank you, Jeb, and thank you to Kat as well for your comments. I don't see any other hands raised at this time, so we will close the public comment period, and just want to again thank everyone for their public comments and encourage you to submit any questions or comments to our mailbox. We'll put that, well, we don't have chat anymore, so we will make sure that we make it publicly visible before the end of the meeting, the email address that you can send those comments to. And with that, I'll hand it back to Director Moran.
Thank you, Ross. Appreciate your facilitation of that. And Katarina and Jeb, thank you so much for being here and providing public comment. All right, we are going to jump into our first presentation of the day. And
just real quick, Ryan and Ross, you guys sound really see. I'm not sure if there's a problem with the microphone in the room or if it's the microphones you guys are talking into.
Is that any better?
No, it's very like
robotic sounding.
Test. How's it sound for others in the room?
Not
no,
good.
it's
the same.
Yeah. Are there multiple microphones on? I know sometimes we get that feedback if there's two microphones on at once.
Let's try just one. Just one microphone is on.
It still sounds the same.
Yeah. We'll all take over because I'm next on the agenda, and that'll give you 10 or 15 minutes to see if you can sort out the sound in the room. Hello, everyone. Next slide, please. I am Judy Zerzenthul, the Chief Medical Officer, and this is a quick report out about the last Primary Care Spend Advisory Committee. Next slide. So the things that we talked about on April 23rd included the cost board priorities, primary care access, utilization, some of the data that was shared with you the last time you guys met, workforce development and discussion. Next. And one thing I want to note here, we talked some about how the cost board priorities are interconnected. And in our last meeting of the primary care committee, we talked about healthcare consolidation, and we'll touch on that again in this meeting. But there's definitely a connection there that we had conversation about. Next slide. So there were a number of discussion questions. We asked the Primary Care Advisory Committee after sharing some of the market consolidation information that you have shared that are on the screen. Next slide. And I think we heard some interesting feedback. There were definitely some risks and opportunities identified in terms of concerns about increased prices and reduced competition and the potential for certain services to be lost, but also some benefits, as we just heard in some of the public comment about the potential for improved care coordination for patients and also easier for providers to refer to specialists. So the key takeaway and question that the Primary Care Committee asked is sort of, are there ways to have market oversight where we have the benefits of consolidation, but also oversight of the drivers that are increasing cost? Next slide. We spent about half of the time on the topic of primary care access, utilization, and spending. Next slide. And I think this is data you have seen before in terms of the United States primary care physician supply. This is graphed of PCPs per 100,000 residents. Next slide. And then this is Washington physicians by county. You'll notice both nationally and in Washington, about a third of physicians are primary care providers, and there definitely is a lot of geographic variation where supply and demand does not meet. Next slide. You saw this the last time you met around primary care growth over time, and that the utilization is not changing much, but the average price is going up, with the highest increase in price being Medicaid. But looking at the price per service, Medicaid lags behind all the other payers. And so there definitely is, even though Medicaid has increased, they are not caught up to where other payers are in terms of reimbursing for primary care. Next slide. This is a graph from the APCD of commercial primary care utilization, with higher utilization being in the yellow and lower in the purple. And as you can see, there's some variation there. Next slide. And then this is a graph of the change in the commercial primary care utilization. So while it has gone up in some areas, there are several counties that are in pink that saw some very large decreases, especially in rural areas. Next slide. So some of the key takeaways in the Primary Care Spend Committee was that although primary care PMPMs have increased, it's been slower than other service categories. And the source of that growth really differs by market. In terms of intensity or utilization driven, and primary care spending and utilization vary quite a bit across the state. Next slide. So some of the questions and feedback we got from the committee, they wanted to know a bit more in terms of benchmarks around the level of primary care providers per 100,000 population in other developed countries, which is not something we knew. They also were interested in looking at further analysis of the data by physicians versus advanced practice nurses, and even potentially physician assistants. They wanted to know more about factors that are leading to the fewer number of services in rural areas. I think that is probably just decreased workforce there. And then the average number of visits per member, and sort of thinking about slots for primary care providers and whether that was different in certain areas of our state versus not. Next slide. Also, some more feedback. FaceTime with patients helps providers find joy in their practice and connect with folks. And some questions about levers in the commercial area, about raising reimbursement rates and prioritizing both primary care focus and nutrition focus. Next slide. The second part of the meeting, we talked about workforce and the biggest stressors on the primary care workforce. I think this is sort of a summary of what I shared with you at this last meeting in terms of projected staffing shortages around retirements, fewer graduates, burnout, things like that. Next slide. And we spent a fair bit of time talking about the impact of federal changes, including HR 1 and the around 600,000 Washingtonians that are estimated that will lose coverage when that is implemented, and also the change in non-U.S. citizen eligibility. Next slide. And then also concerns about some of the visa changes, the H-1B and J-1 waivers that could impact pipelines because international students sometimes fill primary care residency slots at a higher rate. And some of the changes that are effective in July on limits in borrowing for health professions, and new lifetime limits on graduate degrees across health professions that I think could limit the number of people, especially if they are not of a high income, that are able to complete this type of education. Next slide. And then some emergent issues in Washington with the accelerated consolidation. There are some consequences for primary care workforce. Professional development and support roles are typically the first to be cut. And we have had some recent notices that show cuts to clinical education and trainer positions. I'll also note here there are 2 hospitals that are planning on cutting the number of family medicine residencies slots that they have, which will further decrease the future workforce. And then some of the changes around patient care that can contribute to increased burnout and loss of leaders. So next slide. Some other Washington challenges are the lower Medicaid reimbursement rates relative to other specialties, payment systems for primary care that are not always structured for team-based care, and underutilization of loan repayment programs in primary care settings. And then an increasing demand for community health workers, peers, preceptors, things like that to sort of round out the breadth of workforce that can be in primary care. Next slide. Some workforce strategies that have been taken up by other states include market oversight. I think you've heard about that and some of the things Oregon is doing that is monitoring consolidation and thinking about workforce as a part of that. There are also efforts in Oregon, Rhode Island, and Florida thinking about value-based care and alternative payment models that are focusing on support for primary care. Florida, in particular, has an enhanced data collection and analysis on Medicaid graduate medical education payments. And then third is increasing Medicaid reimbursement rates for primary care services, which is happening in a number of states. So that is my whirlwind tour, and I don't know if anyone has questions, but hopefully this is a nice tee up for our next speaker, Kevin Grumbach.
Great. We'll do a mic check. Is that any better?
Oh, no, it is not.
Oh, okay. Seems like it's gotten worse.
Yeah.
Judy, can you tee up the next speaker?
Sure.
And just a quick note, if anyone can hear me, we'll be transitioning to interior ceiling mics. Hopefully that's better for our next internal presentation, but if not, please let us know and we'll continue looking for solutions. Apologies.
That sounds good. So next slide. I'll set this up. I am super excited to introduce Kevin Grumbach, who is a physician at the University of California, San Francisco. He has had a long history of working on primary care issues and has been very involved in California's efforts to increase primary care spend and look at what happens with total healthcare cost. I would say he is a true luminary in primary care circles, and I'm excited to have him come speak with us today. So, Kevin, over to you.
Thanks, Judy. Great to be with you. Yeah, it's a long history. Sometimes feels exhausting history, but right now I'm actually feeling energized that we have great potential to do some things to really get primary care back where it needs to be as the foundation of systems. And it's been great getting to know several people from Washington State and the Healthcare Authority as we're putting our heads together across states about how we really work on state policies to revitalize primary care. What I wanted to share with you today is to really think through a bit more of the budgetary implications. And on one of the prior slides you showed, Judy, it had your three circles of three priorities that you're working on, and one was prices and the other was primary care. And so this is a bit of the tension there. If we're moving to increase the share of healthcare spending going to primary care, what are the budgetary implications for that, particularly in a setting where we're trying to put a lid on growth of total healthcare expenditures? So we have a wonderful team at UCSF that have tried to work through in a more quantitative way what this would actually look like using California as a laboratory. So I want to thank my collaborators on this. Juan Carlos Lozana and Samina Ansari are both family physicians who are finishing up their primary care research fellowships at UCSF. Carissa Longo is a pathology resident at UCSF, just demonstrating our interspecialty solidarity on this work on primary care. And Jim Kahn's my generation. He's a wonderful health economist and preventive medicine physician who I've worked with for many years. So this is a group that's done this work that I'll share with you today. Next slide. So how, you all are thinking about, right, setting a goal for spending in Washington State for primary care. So there's different ways people tend to conceptualize what we're talking about. So some of the more common notions is, well, yeah, we just need to invest more in primary care. Let's just find some money, put it into primary care. And the problem with that is we're also all grappling with the problem of affordability and really widespread concern that currently things are unaffordable. So it's not a great sell to say, yeah, we're going to put more money into primary care if that's going to mean driving up healthcare spending as a whole. So then the alternative is, hey, well, let's make it a zero-sum game, and we're just going to grab some money out of hospitals and specialty spending and pharmaceuticals and move that into primary care. And it's not going to be a net increase in spending, but obviously people aren't thrilled with you taking money from their slice of the pie and moving it into the primary care slice of the pie. And what I'm going to show you is that's actually not really how it works for states like ours that are considering these policies. We're working on year-by-year changes in health spending and reprioritizing of health spending so that you rebalance your spending over several years to get primary care to be a higher share of spending. And to do that, what we're essentially talking about is you allow primary care spending to grow at a faster rate than spending on non-primary care spending, but all sectors are going to grow some to get to your multi-year goal of a certain share going to primary care under a limited expansion of total spending. So now I'm going to put some numbers behind that. Next slide, please. So again, this aim is just to quantify that would look like. Let's jump to the next one, please. So this is our context in California. Now, we have an Office of Healthcare Affordability. I think it's a bit like your Cost Transparency Board, but this has real regulatory authority based on a law that was passed in 2022. In 2024, our Office of Healthcare Affordability adopted two policies. One is to double the relative share of spending by all health plans going to primary care by the year 2034. We think we're probably about 7% now of total spending on primary care, and the goal is to get it to 15% across plans in California by 2034. OCA also has authority, though, over total health plan expenditures, and simultaneously, OCA has said we need to limit total growth to a 3.5% annual rate of growth. This is year by year rate of growth, and that actually drops down to 3.0% in a few more years to a lower annual rate of growth. So those are the two policies. The overall spending growth cap has real teeth. There are penalties that OCA can level on health plans. The primary care investment is aspirational. The statute for the Office of Healthcare Affordability did not give it enforcement authority over that, but it, let's just say, has motivational assets that it can apply to health plans in terms of holding them accountable for the primary care investment goals. Next slide, please. What I'm going to show you then is what this looks like over 10-year models to achieve both this doubling the share of total healthcare expenditures for primary care under various different scenarios for capping total expenditure growth. So next slide, please. I'm going to show you 6 different models that are each under these 3 scenarios. So the first thing we did is say, well, let's say we didn't have a state restrictive cap on total expenditure growth by health plans in California. Let's say we look at just where historically healthcare costs have been growing in California. Over the past 20 years, they've been about 7% year by year growth. So the first set of models just say, well, let's say we just kept California with its overall growth rate of 7% per year for 10 years. And let's look at what happens if we keep primary care as the same share of spending, and then a scenario where we double the relative share of spending. Then we look at the Office of Healthcare Affordability policy, which is what we call a strict 3.5% year by year annual growth rate. And again, we model what that looks like if you don't increase the share of spending going to primary care, and if you do. And then we thought, well, let's find something that's a little intermediary. Maybe we can't keep inflating at 7% a year. That 3.5% growth rate is pretty tight. What happens if we have a little more flexibility and it's a 4.5% growth rate? So let me now turn to showing you what the numbers look like. Next slide. Well, yeah, keep going and we'll do. I'm gonna start by just focusing on primary care sector and hospital spending sector. I'll then give you all the data on all the other sectors like pharmaceutical, specialty care, home health, nursing homes, et cetera. But it helps to illustrate, just to take, I think, in all our states, what's currently the biggest chunk of spending, which is hospitals, and compare what happens to hospital spending versus primary care. So this is, all the slides are going to look like this. So the top line is showing in absolute dollars starting in year 1. We modeled this for 2020 to 2030, just using that as our baseline year. So this is, we're starting hospitals right now in 2020. It was $160 billion per year. And if they kept growing at the same historical rate, it would be about a 6.3% annual growth rate. It's a little different than 7% because each sector has its own underlying inflationary rate, but you get the sense that it's growing pretty, handsomely at 6.3%. Primary care has been growing a little bit faster, so that grows at 7.1%. You can see the absolute dollar increase there. All right, that's if we did nothing to shift the relative share of primary care, of funding going to primary care. Now, if you go to the next slide, what this is saying is we're keeping total growth and spending at 7% year by year, but now by the year 10, we have changed primary care spending from 7% share of total spending to 15%. And what you see there is, to do this, if you're under a total spending cap, there has to be some offsets in spending in non-primary care sectors to give room for this faster growth in primary care. What we show here is that hospital spending growth would have to drop from what I showed you, 6.3% down to 4.8%. annual growth rate. And primary care would now grow instead of 7% a year, it would grow at 15.6% a year. Now, a couple things just to be clear about. That 15% is also just coincidentally is in year 10, we're talking about 15% of spending being primary care, but that 15% in this line is actually saying what's the annual rate of growth in primary care spending to get to that 15% share in year 10. So just be a little careful about what percents we're talking about. Okay, let me just stop there. Any question about just what this graph is representing? Just go ahead and jump in if there's something that doesn't seem clear. Eileen, yeah.
I hope you can hear me now.
Yeah.
So my question is, in this, do you have any offset for fewer people going into the hospital because they're getting primary care?
Great. So that is a question that also comes. I'll get back to that a little later, Eileen. This is just descriptively. So it's just saying, this is what the numbers would have to say. Now, how you get there, you'd say, well, that's right. Maybe all that great primary care would mean fewer people wind up in the hospital for avoidable hospitalizations, and that might actually make it easier for you to restrain the growth of hospital spending. So we're a bit agnostic about how you're going to get to this lower hospital growth rate, but one could certainly make inferences that spending more in primary care hopefully would have some salutary impact on some of these things. All right. Next slide then. So now we're going to go to the, this is still, things are, growing at a pretty robust 7% year by year. Now we're going to say, here's the Office of Healthcare Affordability Standard, 3.5% annual rate of growth. So here you can see it's tight. Again, the reason, the hospital is a bit lower than 3.5% reflects differences in some of the historical growth rates that factor into our formulas here. But you see, it's pretty tight. And now what happens if by year 10, we want to shift 15% of spending now going to primary care? Next slide, please. Okay, so here you see primary care would grow at about 12% year by year annual growth rate. And it'd go from about $30 billion a year up to $80 billion. So it'd have substantial growth. Now you're talking about hospitals have to really tighten their belts. Under this scenario, hospital spending would have to go down to about 1.5% year by year growth. Now there's still some growth. It's not no growth, but in order to offset the increase in spending you're going to need for primary care, one would really have to slow down hospital spending growth. Now, again, it's not a flat line. I want to make that clear. You're not saying there's no room for growth, but I'll leave you to judge how that feels to hospitals to grow at 1.4% per year. So then we said, okay, listen, Office of Healthcare Affordability, maybe hospitals aren't going to be thrilled with this. Let's say you said, let's give you a little more room health plans and go to 4.5% per year in your limit. So this is what it looks like without shifting more spending to primary care over time. And then the next slide shows you what it looks like with shifting spending to primary care. So again, you have a little more breathing room for hospitals at about 2.5% annual growth rate, and primary care here is growing at about 13% annual growth rate. The next slide just summarizes all of what I've just shown you. Again, just looking at hospitals compared to primary care. The first two bars in blue are under that historical growth rate of 7% overall, and it shows you with and without a shift in the relative share to primary care. I think the bars I'd like you to focus on, look at the first green bar and the last orange bar for hospitals. So that's a 2.7. So the first green bar for hospitals is what would happen under the OCA strict 3.5% cap if you didn't increase the share of spending going to primary care. And the final lighter orange bar is what the hospital growth rate would be if you do increase your share of spending to primary care, but now have a 4.5% total expenditure growth rate limit. My point here is being, one of the things we'll get to talking about is, if you said health plans and hospitals, we'll give you a little bit more flexibility and maybe not hold you to the tight cap of 3.5%, as long as you can justify that increase in total spending as largely being on the basis of putting more investment into primary care. And what you then wind up with, hospitals would have a growth rate under that scenario that would be very close to what they would have under a no primary care investment strategy, but with a very strict 3.5% cap on total healthcare spending. And then the right set of bars just shows under, again, summarizing each of those scenarios. And you see under all of the scenarios, if you increase your share of primary care spending, even in the strictest one, you're still talking about, at least 12 or so% annual growth rate in primary care. The next slide now is going to be a very busy slide. You have a copy of this slide, so I'm not going to go through each one of these cells. This is now just looking at, okay, I've shown you primary care and hospitals, which are the first two rows, but this is what it looks like for the home health sector and pharmaceuticals and specialty care. And again, you can see each of these paired scenarios of with and without increased share going to primary care. And you can see, like specialty care, they look similar to hospital spending under the tight 3.5% cap and the increase in primary care share of spending. Specialty care would be down around 2.6% annual growth rate. It'd be up to 3.7% if you move to the 4.5% annual growth rate in total cap. It's interesting to see, for example, which is it turns out the fastest growing segment historically in California has been home health care. So you can see that actually in all these has a much higher growth rate if you look at row 4, but that's only about 5% of total healthcare expenditures in California. So even though it's a fairly fast rate, it's really a very small share of the overall spending, and you don't get a lot of offsets to put into primary care by controlling that sector. Next slide, please. So this is, Eileen, this is your question. Again, this comes up. How you actually manage your spending and say, gee, what is there going to be financial ROI from the greater investment we're putting into primary care that would help with lowering unnecessary use of emergency departments, acute hospitalizations? Would it help with pharmaceuticals if we address polypharmacy and focus on generic spending? The research literature is honestly mixed about this. Some studies show, very high return on investment, up to greater than $10 savings for every dollar spent. There's some that say, it's maybe not much at all. And so it really depends what study you look like. So this is really just saying, this is what the numbers would have to look like. This is what spending growth would have to be in all of these sectors if you're going to have to simultaneously try to keep some limit on overall spending growth while you're at the same time increasing over time the share of spending going to primary care. So I think this is maybe my last slide. We go to the next one. Policy implications. Yeah, I mean, if we were in a different economic time and we said, sure, let's just raise a bunch more money and just start putting more money into primary care, and it's fine if that causes some acceleration in total healthcare spending. That's the way we're going to invest in primary care. Sure, other sectors would be much more comfortable with that, but I just don't think that that's a viable approach in the current moment in time. I think our computations say, it's still probably feasible to achieve a relative doubling of primary care in Washington State. I think you're talking about 12%, for example, even while you're trying to limit total expenditure growth. But there are going to then have to be offsets in spending growth in other sectors. Again, we're not talking about like hospitals tomorrow just cut their spending and move money out of hospitals into primary care, but they definitely are going to have limits on growth to make room for allowing more of the growth to happen in primary care. And that's the same for other non-primary care sectors. And I think states are then just going to have to contend a bit with what's the right balance here? How much growth are you going to aim for in primary care? And then what are the implications for spending growth in other sectors? And what's going to be a reasonable cap to aim for in Washington State to sort of get to those twin goals? I think that's my last slide. Great. So again, this is modeling, this is forecasting, and it's really just trying to put some numbers for folks like you who are deliberating and with the healthcare authority to say, yeah, let's really get real about what are the budgetary implications when we're trying to simultaneously achieve these twin goals of containment of total costs, growth, and greater investment in primary care. So maybe you could pull down the slides now so I could see, well, maybe you have your placeholder slides you need to keep up there, but that's great.
And thank you, Dr. Grumbach. I think we have some time for questions. Are you able to hear me
Yeah.
okay?
Yeah, absolutely.
Okay, great. Okay, I see we have a hand in the room here. Emily, please go ahead.
Thank you, Dr. Grumbach. Well, first I want to say thank you so much for this information, because it's exactly the conversation that we have to be having in this body. Yeah. If we want to be investing in primary care, we have to also have a parallel conversation about how we pay for that. So this is very interesting information. I have just a baseline question in looking at the categories of spend that you've pulled out. How should we be thinking about primary care versus hospital, ED, when we know there's overlap in those two categories?
Yeah,
so for example,
yeah, Audrey, so this is not about where people are employed. This is actually about the services delivered. So that's not, so a physician who's employed by, let's say, family doctor like me who's employed by a hospital, that would show up as primary care spending if it's for ambulatory primary care services. Am I correctly interpreting your question?
Yes, thank you. That's helpful.
Yeah, so it's not about, it's about the type of services and who's delivering it. And that's what constitutes primary care. The hospital would be acute hospital services, as well as emergency department services are included in that category.
And so the categories are not mutually exclusive, right? When we see
they are. No, these are mutually.
Well, they are mutually exclusive.
Yeah.
But when we see an uptick in primary care, that doesn't necessarily mean that we're not seeing that spend at hospitals.
You'd have, yeah. So what you would say is, I think it's a distinction between, I know what you're getting at is the primary care being delivered in the context of a hospital run vertically integrated system? And in that case, yeah, then you would say, yes, for a big hospital system in health system in Washington State that's centered around hospitals, the services that are primary care delivered by that health system would show up in the primary care category of spending here, and the services delivered for acute care inpatient services and emergency department spending would show up in the hospital sector, even though that would be services provided by that integrated system. Is that?
Yeah, it's very helpful. I'm thinking through, right? You're talking really about the arc of transition of services over time. So I think it's important to think through, well, any given hospital that's providing important service to the community, if you're investing in primary care, that doesn't necessarily mean over time that hospital will do fewer services overall.
God. I think what you said, to the extent that they are, the owners, let's say, or managing those primary care practices, you're right, they will benefit in terms of their revenues, right, Audrey? That's a really, actually, thank you. You've just given me an aha moment that I hadn't thought of. You're right. That money would still flow into their health system from the increased primary care spending. Am I correctly interpreting where you're going with this, Audrey?
Yes. Then for consumers to benefit from a spend perspective, then there would also have to be parallel considerations about ensuring that there's a site neutrality policy in that.
Yes, I think you get into all those sort of things, but I think that's a really, thank you. It's very intriguing, because if health systems could really dig in on primary care, and you're investing more in primary care, their revenues would go up. And so you could see, so those offsets, quote, we say there's got to be offsets to inpatient spending. If both the inpatient spending and the primary care services are all delivered by a large integrated system, those offsetting revenues all then stay within the system. So in some ways, it's not so, there's more ability to maintain then some wholeness to your revenues as a hospital system.
Thank you, Dr. Grumbach. I see we have Kim Wallace with a hand up. Go ahead.
Oh, yes, thank you. So my question is very similar. Emily, that was you speaking, right? On Audrey's computer. So what are your thoughts about the impact of possible changes to sort of who's providing the service, where they're providing it, and of course, margins? The people it seems like entities will be seeking, not just revenue, but they'll be needing, certain margin. to experience that. So it seems like when you were showing the comparison of the different scenarios, my mind was going, well, it seems like there could be sort of changes because of decisions through time that the various provider entities are making.
Yeah.
And so what would end up being experienced as growth in costs or numbers of services or whatever could be impacted by those choices and decisions and sort of reactions by the various parties, right?
Yeah. Yeah. And is it okay if I'm first name basis? I just said Audrey.
Oh,
Kim.
certainly. But no, so, and I appreciate how you said that this is modeling, this is sort of just this is kind of out of the gate, high level modeling. And then of course, we're thinking of, all of the variation, the things that can happen, right?
Yeah.
So I know very much appreciate it, but do you have any thoughts about that, about the impact of those kinds of changes?
This is great. That's exactly right. So I think you're interpreting this as we intended. Here's what the numbers would have to look like to get 10 years from now where you want to be with spending and overall cost growth in a state. Now, how you then implement it in a way that's going to achieve what you really want to happen for patient care services. Okay, now that's the interesting part. I think you've already raised a really interesting point is within large integrated systems, then it's not such a zero-sum game because you can grow your primary care sector within that system. And even if you're having to belt tighten in some of your acute care services, for example, to meet this, and that could actually be something you could really strategically lean into very much in a more integrated system. I think then that, the part here is that those 12, 13, 14% year by year increase in primary care spending, the goal of that is you want those monies to go into frontline practices, right? That's your goal in Washington State. That's certainly my goal in California. We need to rebuild the infrastructure of primary care. We need to hire all the staffing we need. We're talking about behavioral health integration. We're talking about clinical pharmacists, community health workers, probably to make it more attractive for physicians, nurse practitioners. Some can go to compensation, but all this stuff in our regulatory policies, we want to make sure there are clear directives that spending flows to frontline practices. And I think this is one of the challenges, Kim, because you say what we're showing here is health plan spending growth, right? That's what our regulations apply to, is private health plans, Medicaid plans. It's not going to work if the plan says, we just met Kevin's trajectory. Our year by year spending on primary care grew, and all of that sticks in some giant system and never gets to frontline practices. And they say, and I'm a family doctor working this, and I say, those plans say every year they're spending 10, 15% more on primary care. I don't see any more staff in the clinic. I don't see, the resources here to help us take care of patients better. I think now when you have private equity, you have for-profit enterprises, you got to be very careful that spending isn't extracted as profits, and it suddenly becomes, that's a lot of investors are going to get into primary care because it looks more profitable. So I think in your regulations you're considering along with your primary care spend goals, I think you really want to think about accountability and even audits that if health plans are spending more in primary care to meet state spending goals, there is then some mechanism to track the flow of funds to say they're actually getting to frontline practices and not being extracted in a way that then is not going to benefit patients nor really allow you to fortify your primary care infrastructure and make it a much more viable part of healthcare.
Thank you.
Yeah.
So, Dr. Kornbach, thanks so much. I think your point is incredibly well taken about getting the dollars to the front line. And I'm trying to figure out whether you do that through what you're telling a health plan to do versus saying, this is the model of primary care that we want more money spent on.
Yeah.
And you're doing it not just at the insurer, or issuer level, but you're also doing it at the health system level.
Yeah. Yeah. No, I think so. I think some of you know, if I had my preference, I'd create just a common fund. I'd actually pool the funds together and have an entity that's directly paying primary care practices, even if they're lodged within a larger health system. I think that may be a discussion for another, group within Washington Healthcare Authority. But I actually, to me, I'm starting to couple with this, with really rethinking the whole financing structure for some of these reasons, to really be able to have a more coherent way of distributing the funds to practices and make it a much more administratively simplified process. That said, though, I think one of the things people are talking about with this is maybe we need more guidance and some rules about how the spending works and the payment policies. For example, I've been very intrigued with the Massachusetts Medicaid program, where in their ACO models, they have started to put more money into primary care as a share of their spending that goes through ACO kind of managed care entities. And it's largely capitated, and they tier their capitation based on the capacity of the primary care practice to deliver advanced primary care. For example, you get your base capitation amount if, all right, it seems like you're open for business, you meet basic entry quality standards, and so forth. You meet the second tier for a higher payment if you say, oh, we are actually doing routine screening for depression and substance use disorders, and we're able to do some population management outreach for closing care gaps. And then you get the highest tier of patient if you say, well, payment if, oh, we're not only screening for depression, we actually have integrated behavioral health services as part of our primary care practice, or a very close contractual relationship with community-based behavioral health clinicians who are part of our team. So in a way, then you're starting to say, we're really going to pay for capacity. And so then it's not just saying, oh, health plan, this commercial health plan has just upped their rates under either a fee for service or even some perspective payment. You're basically saying we're providing more of a structure where you really are saying the higher payments are going to be directly tied to implementation of the elements of advanced primary care. I think then states probably need to front load some of this or work with health plans. Again, if you're doing this through health plan intermediaries, because, well, it's a bit circular. I'd love to get that highest tier payment for integrated behavioral health, and I have a clinical pharmacist, but how do I even begin to hire those people unless I have some revenues to do that? So you might say, we'll front load it for 12 months on the condition that by the end of 12 months, you have to have those things in place to justify continuing to get a higher tier of capitation payment and things. So I think there's a lot of creative ideas going on with your payment policies. And that would be another way that helps with accountability for the spending, to say, okay, this is how we know it's getting to frontline practices, because they're only going to be able to sort of achieve the higher payment spending or meet the criteria, whether it's through a state entity or through rules that are shared by plans, because they are actually implementing the elements of advanced primary care. And then if you're in a large integrated system and saying, sorry, big health system, you're not getting these higher primary care payments unless you actually are on the ground starting to show you're implementing what's needed for primary care to work better for the patients and communities you're serving, and to make it a much more viable career for those working in primary care.
Thank you. Well, appreciate the discussion about accountability and how you move forward in practice transformation in a meaningful way. One difference that I want to note between California and Massachusetts and Washington's spending benchmark is that we don't have any teeth in our spending benchmark. And so we've been routinely exceeding the spending benchmark year over year. And the results of that, of course, transfer down to consumers. In Washington, we're coming up on our 5th year of nearly double-digit rate increases in the individual market, for example. And so I think when we have this conversation in Washington, we can't have the discussion about investments in primary care unless we are also paying attention to the offsetting piece. So I think I'm not sure if there's a question there,
No.
but it's a consideration for us in Washington because we don't
No.
have any kind of a hard cap. Although I think that was originally the intention in the law that we had here in Washington. There's nothing to contain or retain any piece of accountability.
That's a problem, Audrey. I mean, I think I think the climate in California politically and from a policy implementation is we have the advantage because I think the total spending caps that have real teeth, there's real penalties that our Office of Healthcare and Affordability can impose, sets for a different dynamic. Because I think you're picking up on a little bit of what's been implicit in my presentation is this is the discussion I'm having with people at our office is, they can give exceptions to health plans for exceeding the total expenditure cap. And that would be, I think one thing they would strongly consider is if a health plan says, yeah, we came in at 4.5% these past 2 years, but we actually have, a lot of that is because we actually have followed through on spending more in primary care, and that they'll have a much better time of having that accepted by our Office of Healthcare Affordability than if they come in and say, oh, we're coming in at 6-7% year-over-year growth. And boy, primary care as a share of our spending has actually gone down in that time. I don't think they're going to get a lot of sympathy for that to avoid, the state saying, no, then you're going to have to pay a penalty. Now, whether our penalties are large enough to really motivate plans, but I think that it's a really good carrot we have for the primary care investment in being able to say that could be a way to justify some exception to come in above the total spending cap. So, Audrey, if I hear you saying you have kind of goals you'd like for primary care spending in Washington State and maybe some wishful thinking about controls on total spending, but there's no enforcement mechanisms for either of those. Am I hearing that correctly?
That's right. Yep.
Yeah. Then that's hard because then you are potentially in a little bit of the scenarios. Well, it's hard then with no enforcement at all, but the primary care spend the easy way out for health plans and say, okay, we'll meet your primary care spending goal, but then we're just going to drive up our overall healthcare spending to account for that without, doing the hard work of finding offsets and controlling expenditures elsewhere.
But I think your modeling is still really important for us here because it shows how there can be that relationship where care is improving over time if you're able to set it into that cycle. So thank you.
Yeah.
Are there other questions for Dr. Grumbach and the board? Thank you, Dr. Grumbach. Super illuminating, enlightening discussion. We appreciate your contributions and your thought leadership and for being a good neighbor and sharing with your friends up north. So thank you so much for that.
I feel great solidarity with our Washington, Oregon, California, Ecotopia land, and I hope we can sort of work together and make progress collectively on these efforts. I really, really appreciate you inviting me and allowing me to share my thoughts about this, and I'm happy to be a resource if I can be helpful at all. I think we're all have some common purpose in this. So thanks, folks.
Wonderful. An alliance indeed. Okay, we are going to move to the next portion of the board meeting on the cost growth analysis work. So if we will take you back to the March time period when staff had presented some initial findings from the driver analysis from the all payer claims database to identify some of the major contributors to the spending growth in Washington. We had a lot of questions, a lot of conversation about that discussion. They have gone back to provide some additional follow-up detail, some follow-up analysis from that discussion, and there was a lot of discussion on outpatient services, some questions about retail pharmacy, some classifications of what was listed within the other medical categories. And so we wanted to bring Harrison back to this group to review some of those report out. So Harrison, it's good to see you again. Thanks for your work. Welcome back. And we will turn it over to you.
All right. Thank you for that introduction, Director Moran. And let's dive into it. So today's presentation is going to be sort of a quick update to let the board know where the staff is going analytically to begin to answer the questions that we heard in that March meeting, to give a few quick answers and references to the data we saw, some new visualizations, and really just sort of continue the conversation that we had in March. So a quick reminder for the two sort of data work streams that feed into the board's work and that we rely on really heavily. We have two of them here. The performance against the benchmark is that really high level, sort of more comprehensive spending information. And that allows us, sort of a high view of what's going on with spending. And then we have this cost drivers analysis, which really allows us to see within those trends, what is really growing the fastest, what is pushing growth, and sort of looking more and more deeply in a more granular fashion as to what is underlying that growth that we're observing. This slide should look familiar to folks. Presented a version of it in March. And what we see here is when we look at claims data from 2017 to 2024, we can see overall growth rates in different markets, and then how different service categories contribute to those overall growth rates over this period of time. A few things to take away here. We see in the commercial market a growth rate of about 58% over that period of time, and overall, across the state, a growth rate of about 64% in terms of per member per month spending. And one request last time was to provide a little bit of reference for this, sort of a benchmark, if you will. And to do that, we can look at the factors that comprise our benchmark, this sort of comparator that allows us to see, are we growing too quickly? Are we doing sort of okay? And when we look at median wage, which is one thing that that builds into that benchmark calculation, we can see that over the same time period, median wage only increased 41%. And then if we look in a different way, if we look at gross state product, we can see that that increased in that same time period about 63%. So sort of high level takeaway here is, these claims data that we're looking at and these spending trends seem to be sort of one of many indicators that show the growing affordability crisis in Washington and really point to specific drivers as things that we may look to for further interrogation. One thing that we did get into a little bit last time in terms of the main service categories that are driving that growth, right? We had retail pharmacy, we had hospital spending, whether that's outpatient or inpatient, kind of depends on the market we're looking at. And then we had this strange, mysterious category of other medical. A little bit more information as to what's in other medical. It certainly includes things you see here, durable medical equipment, freestanding diagnostic facilities. But really what this category is sort of a catch-all. If claims don't cleanly fit in any of the other service categories, they're categorized into other medical. And so, we can sort of say that if this other medical category is growing faster than others, we have this sort of growing swath of uncategorized spending that we could consider looking into further. Another thing to note, again, is that this does not include non-healthcare services. So things like gym memberships or whatever else aren't in this. This is healthcare services that are not otherwise categorized. I should say claims that are not otherwise categorized. So we can look at cumulative growth in the commercial sector for the main cost drivers, and we see that data here in terms of the panels you're looking at. This is data from 2017 to 2024. We have PMPM spending on the left, utilization in the middle, average price per service on the right, and the different colors are different service categories. And what we see, interestingly, just sort of walking through it quickly, because I believe we've seen this already, is a really weird utilization spike in the 2020 to 2021 timeframe that doesn't fully return to baseline after that period. And then, looking at price per service, we see an interesting acceleration in the price per service in many of these cost driver service categories, including other medical. We can summarize that through this visualization here, and just want us to focus in on this lower right corner of this figure. And just a quick explanation, these triangles are representing changes due to price, the circles changes due to utilization, so folks using the service more or less. And what we see is in the commercial market, we see that the increase in the other medical spending is really due to a balanced contribution of increases from price and increases from utilization. And that's a little bit different if you look at the other markets. Medicaid and Medicare Advantage seem to be driven more by price than by increases in utilization. And that's something that, broadly seems to be true for other service categories as well across markets. Speaking very broadly there. We can take this data and look at it a little bit differently. And instead of looking at different service categories alongside each other, we can look at different markets. And that's what you see here. So again, PMPM on the left, utilization in the middle, and price per service on the right. And this time the different colors are different markets. Commercial market is in purple, Medicaid in sort of lighter blue, Medicare Advantage in light green. And what we see again is that spike in the commercial market sort of mirrored in the Medicaid market, but not entirely, and really not mirrored in the Medicare Advantage market. So seem to be some important cross-market differences there. And then when we look in terms of other medical changes in price per service, we seem to see this increase in price for the commercial market, the Medicaid market, but again, less so in the Medicare Advantage market. So these are all, pretty interesting cross-market differences. And one thing that we can sort of ask ourselves before we dive more deeply into these analyses are, could this be a quirk of the data we're looking at, or do other groups looking at spending data see something similar as well? And the answer is broadly yes, they do. When we look at the national accounts, national health expenditures, we see that categories, they break it apart a little bit differently, but categories roughly corresponding to those subcategories that fall into other medical seem to increase as well between 2020 and 2021. That includes things like durable medical equipment and physician and clinical services, which include things like testing services that were again in that other medical category. And then when we look at our neighbor to the south, they have a very similar sort of catch-all category, and their other spending also has increased dramatically. Interestingly for them, it seems to be an increase more driven by price than utilization. So you can see this figure here on the right. The blue line is price, the solid blue line is price, the dotted blue line is utilization, and we can see seemingly more contributions from price than utilization, a little bit different mix than ours.
Harrison, can I ask a quick question? Can we drill down a little bit on the other medical?
Sure.
So would the other medical be like freestanding imaging, freestanding labs? So like LabCorp, is that what we're talking about? Versus a hospital that might have an in-house lab? What are we talking about there?
Yeah, so fantastic question. I think the sort of top line answer, and I think we have some other members of the cost board staff on that can correct me if I'm wrong, but roughly yes, that it's a catch-all. There's a lot of things in there, but those freestanding diagnostic testing facilities that you're talking about would fall in this category.
So, I mean, when I'm looking at the average price per service, right, on the trends on the other medical, I'm just thinking about trends that we're seeing in ownership, right? Like what are we seeing in terms of for-profit versus not-for-profit? What are we seeing in terms of PE acquisition? And is there any, is there a difference in the business aspect of freestanding lab and freestanding advanced imaging that's different than the trends that we're seeing in terms of like the world of for-profit investments on the hospital side, right? We know the vast majority of hospitals in Washington are not for profit. So
Mhm.
any information I think that you could share about ownership trends, PE, and I think I'll have to go back and look at the PE work that we did at OIC and see whether we saw what kind of activity we saw on these kinds of diagnostic providers. But it seems like something that it's worth looking at, given that both we and Oregon are having the same experience. Because when I think about hearing aids, right, our hearing aid mandate on the commercial side didn't go into effect until after this, well, or at the very end of this period. And it's not super expensive. It's just not.
The thing I was wondering about is if it includes labs, is the spike in utilization that we see in 2020, 21, is that COVID test?
It could have been.
But
Well,
then why didn't, and it went back down, right? But never returned fully to baseline.
To baseline.
Which might get at some of your questions about investment acceleration in that market with the rise of COVID and whether those investors just stayed in.
Yeah.
Mhm. Yeah, I think
Imaging
points.
stuff too.
Yeah,
I'm
really
sorry,
well
go
taken.
ahead.
Oh yeah, I think that sort of the hypothesis that you're circling around is very similar to one that we've considered as staff, and I think it really just sort of requires future work to dive in a little bit more deeply. But yes, this spike in utilization that we see, especially in the commercial market, could very well be due to changes in testing and COVID surveillance that maybe shifted the market to be a little bit different in a way that was lasting and durable, and perhaps those are accompanied by changes in ownership that we can look into certainly as we dive deeper into these trends. Certainly provocative, but yeah, can't say for sure yet that those are testing facilities that we're seeing driving that overall trend.
Thank you.
And I guess sort of teeing us up for future directions, and really would appreciate board members' thoughts on guiding this work a little bit, if there are any sort of different directions that you would like us to go with it. But for other medical and other service categories as well, one of the next steps is certainly to break these broad categories into meaningful subcategories. And that may take some time, but really important to understanding a little bit more these what is happening, when we look at these broad categories, what is driving those overall changes. Another way that we can look at things is through procedure code level analysis, where we're looking really at specific types of services, not averaging over several different types, looking at a specific service and seeing, across markets, do we see different trends? And that could, in this case, be, a specific type of test if we're testing that diagnostic facility hypothesis. So that relates to our work with other cost drivers and breaking apart the other medical category a little bit more. Another thing that would be really helpful for this that staff is working on currently is including the Medicare fee-for-service data, at least as far as we have it, which I believe will be included in the legislative report. The board members will have a chance to review that before that is incorporated there. And that data will not be up to 2024 due to sort of the way things are reported, but we will include it as much as we have, so we have sort of that other market to compare against. With that, I'll pause here. Before I hand it back over to Director Moran, are there any other questions or comments from board members?
Harrison, another question. So we report out on retail pharmacy, but the really expensive specialty drugs are physician administered. So are they showing up in the outpatient category, or where do the physician administered drugs show up? Like the cancer meds and the rheumatology, right?
Yeah, that's a really fantastic question. I want to give you an answer live, but I will take that back to staff, and we can follow up shortly. Might be able to get you an answer within this meeting, but I don't want to speak out of turn.
Yeah,
So
I mean, we found usually those meds are in the medical benefit. They're not in the separate prescription drug benefit. And that's probably the place where you've got the highest utilization of the really high cost specialty drugs. Yeah, show up both ways. Yeah.
That's fine.
So they'll show up in inpatient and outpatient. Yes. Where they're administered. Yep.
Yeah, we certainly do have a good component of medical pharmacy wrapped into our hospital spending. So certainly something is being captured there. Whether it's the entirety is sort of what I'm a little unsure of. So we can bring that back to board members. And with that, I will hand it back over to Director Moran.
Lee, did you have one more question? I was just going to follow on to that. Thank you, Director. I don't want to make work for staff, but if that is a knowable, if that's a knowable trend that we can see is the drug spend there, I think that would be interesting because we only have the retail side, and I think that's an important piece to pull out if it's possible within the data. If it's hard, then let's not do it.
Yeah, thank you. Yes, we will come back on that and how difficult that would be. That may require going through individual claim level to try and decipher.
DRGs.
But we will look and follow back. Thank you.
Thanks.
Great. Harrison, thank you so much. All right, we are going to take a 10-minute break. So why don't we be back here? We're a little ahead of schedule, which is really good. Why don't we be back here? We're going to take like an 11-minute break. 3:35. 3:35. Yeah. All right, we are 30 seconds past our schedule. So we'll keep ourselves in line here. Okay, want to welcome our colleagues, partners from the Washington Health Alliance. They are going to provide an update. Drew, good to see you on their 2026 report. So the report that Drew's going to go over is a review of cost, quality, utilization across the healthcare system, known as their annual community checkup report from the Alliance. Drew, thank you so much for being here, and we appreciate the time that you'll be able to spend with us and the board today.
Yvette, thank you very much. And I'm assuming you can hear me?
Yes, we can.
Very good. So, yeah, I'll spend a little bit of time talking about what we reported on. I think it was in February, and there's a little updates in there, so I put some of that information in there as well, and we can, hopefully have a little time to, ask questions, etc. So if we go to the next slide, these are things I was going to talk about. So both our total cost of care, quality. We've talked a lot about primary care already. I'm a primary care doc, so I'm going to keep talking about it. A little bit on patient safety, and then some, off of Drew's mind, what potential solutions might look like. On the next slide, it's really what our community checkup looks like. It's both commercial and Medicaid carriers. We usually mostly talk about the commercial side of things. So we've got multiple carriers, fully insured and many self-insured customers, our data suppliers. It allows us the opportunity to look at both the cost of care as well as the quality of care. Our providers and members of the organizations help design sort of how we measure things and how we report. Our first report came out in 2008. We developed a common measure set for the state back in, I think it was 12 or 13. And some of the things that we've done since that time is be able to pull in and confirm provider representation in clinics and groups so that we can tie some of those results back to those providers. And then we recently did what we call geographic insights. It was a way to get to equity using the area deprivation index and going down to the census tract level to be able to show differences in both quality, cost, access to primary care, use of your services, et cetera. So it's a pretty robust all payer claims database, which the next slide will show you kind of what it looks like. It's going to look pretty similar to the state's APCD. We may have a little bit more self-insured customers. This report is full year 24. So we have the run out of claims. We look at state averages in general. We do, and one of our benchmarks back, when we first started was looking at NCQA 90th percentile as the benchmark that we wanted to attain. So that's what we would call sort of the best practice. And the other piece that we do every year is we allow providers to make sure that their rosters are accurate. They can get access to patient names if they want them to make sure they're part of their practice, et cetera. So we want to make sure that vetting process is clear and transparent as well. And then if there's any discrepancies, we work with them. Yes, you can go to the next slide. So the community checkup has many different components. So you'll see across the top there, we've got scores, we've got highlights, we've got reports. The highlights section is what I look at a lot because it's got all these different components to it. So if you're really just looking at, hey, I just want to look at quality, you can do that. But if you want to look at it in some other different ways and different slices, and I'll show you a couple of those as well. So that's one way you can go look at it. You can get lost in there for quite a while. Our board has made this publicly available, and the data suppliers have allowed it. So that's great. We also do other work behind the scene that is not publicly available. We may do it for an individual entity. We've done some for the HCA in the past. We do it for individual health plans. We've done it for purchasers so that they can look, within our guidelines in terms of the use of the data. They can look at how they may be compared to the state average, et cetera. So there's lots of ways we can use this behind the scenes. The next slide is just an update on sort of the percentage increases. We were able to get some additional data from a prior year, so we could look in, and we were able to fill in some of the gaps that we had with some data that we weren't able to use because it wasn't clean data before. We were able to clean that up. And like you saw on the last presentation with sort of a 63%, 64% increase over, I can't remember, 6 or 7 years. This is just a year-over-year change. It's a little bit higher than the national averages of 7.2 at 8.9. It's coming in a variety of different places. We've done some work on the primary drivers of within each of these categories. We provided that to our, at least at the state level, to the purchaser members. But an individual purchaser is going to look really different than the state because they have a different population, they have a different geography, et cetera. So, if people are interested in, what we're seeing from, the primary drivers, we'd be open to doing some work related to that as well. The next slide is also sort of how we drill down into kind of those driver mixes. So, the change in the population. So if population gets older, gets younger, that will have an impact on sort of how we're seeing a cost change. Utilization obviously is in there, and we like looking at that at multiple different levels. We use a Milliman tool to be able to get the different categories of service, and we were able to look at utilization that way. We also look at intensity of service. So an admission is an admission, but some admissions are worse than others and more intense than others. So we look, is there a change in, is intensity driving that cost change? And then of course there's unit costs. And as we saw in the previous presentation, unit costs may be more or maybe equal to utilization. So it's pretty variable in terms of the service that you're looking at. But let's move into quality. And so the next slide is really looking at some of the quality measures that we have and we've reported on for a while. In our report, you're able to choose between sort of all measures and the common measure set. I just picked our common measure set. Doesn't completely match to the states because we didn't add a couple of measures that the state has, but it's fairly close. Each little dot is a measure, if you will, and it falls within a percentile ranking within NCQA's HEDIS measures. And so you can see that there's a few in the green. That's what we like. That's at 75th to 90th percentile. None of the measures statewide were on the commercial side were above that, nor on the Medicaid side. A vast majority of the measures are below the 25th percentile. I think there's a couple reasons for that. We'll get into, what those might look like. Some of our boards said, yeah, is this just a one-time thing or did it happen over time? So if you go to the next slide, you can see this arrayed over a period of time. And again, these are compared to national numbers versus this just internal to the state. You can see that there's a few more folks falling into that 50 to 75th percentile. So that's actually an improvement and probably the biggest change that I've seen in the last few years. So that's, maybe that's something that's that we can take some comfort with, if you will. But what we do see is that there remains a lot of variation in many of these measures. Some measures, we've topped out at. Some of the early on we were concerned about generics and generic use of certain medications, and some of those measures have topped out at well above 99%. So those almost aren't worth looking at anymore. But if you go to the next slide, I'll just show you a screenshot of, one of the things we show in this report. Each of these little blue dots are, in this case, a medical, I think this was the medical group versus clinics. And you can see each column is a different measure. You can't read them, but you can just see that there's a big range in what the results show. The gold line that's going across is the 90th percentile. So you'll see that, some practices are doing above the 90th percentile and some aren't. The little black dot is the state average. If you go to the next slide, what we do see is there are some best-in-class performance. So if we looked at some common measures, screening tests for cancers, chlamydia screening was one that we looked at because it was a little bit surprisingly low given, especially from an equity standpoint, we were seeing some pretty stark differences in there. So you can see that the state averages and the HEDIS rankings probably aren't where we want to be. The national 90th percentile, is above that. But then you can see some practices that are well above that. So some practices are doing really well in these areas. And so that's really helpful to see. And being able to pull maybe the low performers to understand what the high performers are doing, would be maybe a good idea. And that can help sort of, move that innovation forward. Things like diabetic eye exam, the reason, UW Eye Center and many other ones are well in that 90th percentile is because they have a digital retinal scanner at the site, and they scan people when they come in for their diabetic visits. So it's makes it really easy, goes into the workflow, and you're able to capture that, that important clinical information. The next slide is also looking at the Medicaid side. So Medicaid, pretty similar. Maybe some of the rankings are a little bit better than the commercial side. And then on the next slide, you'll see some of the clinics that are, excelling in, some of these areas. So, it's not all gloom and doom, but there's, again, there's variation in that care. The next slide is a way we've been looking at sort of quality, and we've created something called a quality composite score, and that came about really early on in the process of measuring quality. That the providers and health plans in the state wanted to look at provider organizations compared to the state rather than compared to some other benchmark or other entity. So we pulled together a number of different clinical metrics. There happen to be in 4 different domains. The domains are preventive services, chronic disease. I'm going to get these wrong. Some are related to effectiveness and efficiency. The other one is sort of the avoidable costs, like avoidable ED visits, avoidable readmission rates, things like that. We take that score we can do it by the clinic, the county, an ACH, a medical group, and then we compare them to themselves, and they get a percentile ranking where they are within the state. And that's how we create the composite score. A couple of years ago, we added total cost of care related to those areas as well. Again, percentile ranking very similarly. And then you can see in the little box on the right, it allows you to change how the rankings look based on your preferences. So we call it a preference slider or whatever. It defaults when you first come in to 100% on quality, but you can move it. And so in this case, we said, well, I like quality more than I like cost, so I made it 60% quality, 40% cost. I did it by county, which county showed up the best that way. And you can see that Spokane popped to the top. They have really good pretty darn good quality. So the quality composite score really good from a cost standpoint. Again, this is a commercial population, and so they jumped up to the top. Some other ones you can see down there are in red. That's because they're below the 50th percentile from a quality standpoint, but they're also very low cost, so they moved up because we weighted that cost score. So you can go in yourself, take a look at that. You can look at it by a medical group or a clinic. Even the ACHs, we built it out that way at your request a few years ago and have left that in there. So you can sort of see how things are shaking out that way. The next slide is not, oh, this one also is in our report where we just isolated by quality and just isolated by total cost. So you can see, and this is at the medical group level, so you can see, who jumped up to the top in each of those areas, both by commercial and Medicaid. And I think on the affordability, I find it interesting because I used to work at a community health center that they tend to be more affordable, even when you're looking at commercial populations. So I think that's fairly interesting to see as well. Next slide. Here's where we're getting into sort of the question about primary care. We've talked about it before. I think Kevin mentioned, or if he didn't mention it, up to a third of folks don't really have a PCP relationship. We tried to piece that out, and when we look at our data, we find that that number is pretty close in that 30% range. What we see is people have claims, but they don't attribute to a PCP. And attribution in our model is 2 visits with a PCP within the previous 2 years. If it's multiple PCP, who saw them the most is who gets attributed. So if you've got claims, but you don't have a PCP, you're getting your care someplace else. Could be an ED, could be with a specialist. All that is fine. On the commercial side, another 12% have no claims within the year. That number is not, inconsistent with, many commercial plans. When you take those people who have claims, but no PCP, and you risk adjust them, they just cost more. And you see that both on the commercial side and the Medicaid side. And there's a number of reasons for that. I think the next slide will show some of the impact of not having a PCP. You're just not going to get some of the preventive screening tests done. Those are all those ones in red. Some of them are getting diabetic eye exams, so that's pretty good. And things to avoid, like avoiding imaging for low back pain. If you don't have a PCP, you're probably also not going to get an imaging study. So I guess is that good? I'm not sure. But the other thing is, even people with claims and they have children, those kids aren't necessarily getting into primary care. They're not getting their well child visits, et cetera. So clearly from a quality standpoint, having people in a relationship with a primary care practice will help close some of these gaps that we see across the state. Next slide. And then there's more and more stuff you can dive into in the community checkup. There's a whole section on scores. You can look at each individual score. You can pull it out by how you want to view it. You can do it by a clinic, by a county. We've got health plan data that's more aggregated. Hospital data is more aggregated as well. So there's a lot of ways you can look at this information to, maybe inform where you want to find additional information, or maybe there's an area of focus that you want to get at. The next slide, I think, is one of the things that we do at the Washington Health Alliance. We're the lead organization for the Leapfrog group. Leapfrog's been around for about 25 years, and they came about right after that report to Err is Human came out in 1998. I think Leapfrog came up soon after that, really looking at hospital patient safety and developing metrics for that, the evaluation of that. And they've, have an expert panel. They use mostly CMS reported data, so hospitals already report there, so that makes it fairly consistent. They do have some survey data, like do you have a hand washing policy, and do you monitor that? Do you have an ICU? And if you have an ICU, how is that staffed? Is it staffed with ICU specialists, et cetera? That's 2 of the 7 measures. This year, 8 hospitals got A grades. 6 of them were from one system. So that system clearly is, paying attention to, some of these things. Many hospitals have had, we call them straight A's. So I think it's 4 or 5 reviews in a row with an A. But when we look at the percent of hospitals that get an A ranking versus, the total, Washington has now dropped to 40th. I think Connecticut is number 1. 64% of their hospitals have an A rating. So ideally, we would like every hospital to have an A or B, and probably attainable. And then the other things that Leapfrog has looked at, they've added some work on diabetes care. I mentioned that Evergreen has now received a couple years in a row recognition for that. And then ambulatory surgery centers have been out there kind of on their own. They started, Leapfrog started looking at it from a survey standpoint, but it was hard to get ASCs to become involved with that. They've added external data, so things that they can get and add to that, which will actually take up the majority of how they evaluate ASCs. The first report will probably not come out till the fall, but that was just recently revised in April. Next slide. So just to summarize, I think we're seeing spending being a little bit higher than the national benchmark. So that's, that's something I think we need to continue to look at from a total cost of care, especially year over year. Our data is somewhat limited, so we don't have additional payments that might be made outside of claims. So if there's a value-based contract or value-based payments, we don't have access to that, or a bonus or other things like that. We continue to see quality measures below the national average. I suspect much of that is because of a lack of a primary care relationship, because we see that when you have claims, no primary care, you don't tend to have as high a quality metric in there. However, we see many practices are able to really excel and shine in the quality metric areas. So that's great. I think patient safety is, everyone wants it, but they don't tend to address it in a meaningful way. So I think that's something that should happen. And I think the last slide is just sort of the Drew thoughts. And so, kind of going with the theme of the day, I think you have to make primary care a foundational part of the system. Right now, it is a fee-for-service add-on. Half of what a primary care practice does is not typically reimbursed in that way. So finding a way to make primary care a foundational part of the health system, I think, is really important to help from a quality standpoint, as well as potentially a cost standpoint. When we've looked at some of the equity pieces from a geographic area, there are areas that have more needs than others, and you probably have to invest in those specific areas, and those might be rural areas. We've seen the Washington Rural Health Initiatives, take place, and I think that's a great place to start. I personally think we ought to pay attention to patient safety. Now, we may not believe in leapfrog or something else, but something, we should say it's just not negotiable that you don't excel in from a patient safety standpoint. We still have some blind spots in our data. We know the Department of Health has told the health plans not to release any behavioral health data. So we can't really report much on that. It would be nice to be able to get that so we could help evaluate some of those areas as well. And then because we're a purchaser-led organization, I always think purchasers should buy on value. And value for me is quality over cost, multiplied by appropriateness and access. So I think we currently just buy on volume, and that's probably not the best way to go about it, because if we buy on value, then the market will understand that's what gets paid, and that's where we're going to go. And then I think that kind of goes along with having a culture of health and wellness that's pretty comprehensive. And when I think of that, I think way beyond sort of medical care, but I think of social, emotional, financial, professional, et cetera. And I think that might be my last slide, other than, as a member of the Washington Health Alliance, you're a data supplier. If you want us to do, some additional work, we're happy to do that. And I'll take questions if there are any.
Thank you so much. Questions from the board? Yeah, Emily, go ahead.
Thank you, Drew. As always, amazing work. Thank you so much for this information. This is Emily, by the way. I'm not sure if you can see me in the room.
I can see it.
I was really struck by the slides about the best-in-class quality and best-in-class affordability. And the thing that struck me most is that there are a couple of medical groups that show up in both places. And so I'm looking at ICHS. I'm looking at Multicare Rockwood Clinic. What are they doing right that they're showing up in best-in-class quality and affordability? So my question is there anything that either the Alliance or the state or some combination of both could do to highlight the practices that are happening in those medical groups and bring them forward in some kind of a learning collaborative model for the practices that are not showing up on the best-in-class?
Yeah, I think it's, there's so many places you could go look, Emily, that, to try to figure out where do you start. I think you just got to pick somewhere between 1 and 3 things to focus on, and then focus on them really hard for 3 to 5 years, because it may take that long to get some of the poor performing practices to get up to the level of the best performers. But if you try to do what we have today with value-based contracts, and every health plan has their own value-based contract, and every provider has 15 health plans that have a contract with them, and they've got 150 different measures, that's not helpful. So I think if we decided we want to focus on X, Y, and Z, then we bring in those practices, and we can convene them to do something like a learning collaborative. We're doing something right now on chronic kidney disease, mostly because we saw a big gap in the care that's being provided, because people just aren't being screened. We also wanted to expand some of the metrics related to kidney disease that are in the guidelines, but not in any of the national metrics. So you'll see that report being posted probably next week. But bringing practices together, say, what's the issue? Why does screening not happen? What's the issue about treatment? What's the issue about, follow-up? How are you making the appropriate diagnosis? All those things are really important. And I think, some of these places, Rockwood Clinic, Multicare does a pretty darn good job. And Spokane is pretty good from a price standpoint. So, when you compare them to the state. So I think it's the way you practice and how you have your practice organized.
Yeah, and I appreciate that, Ben. I appreciate your thought about not trying to look at the whole elephant instead of focusing in on a couple areas. But, ICHS particularly is striking because that's not a patient population that is not complex, doesn't have language barriers, doesn't have immigration status barriers, all the other pieces. So I wonder if there are a couple of practices that might be able to teach us some things more broadly about their culture and how they think about affordability.
Yeah.
And so Drew, on that note too, I mean, when you think about the community clinics, they have a pretty, thinking about how they approach their primary care models, how and whether they approach bringing behavioral health services into the integrated model. Because you've got, right, clinics that are working with, as Emily said, some of the most complex people. And so what can like the non-CHC side of the world learn from the CHC practice models?
Well, you were just talking to Kevin Grombach about funding. So
Right.
I think the FQHCs are funded a little differently than normal practice. Typically 2 to 3 times higher reimbursement per visit. That helps. That allows you to fund some of the things that aren't, that need to be done from a chronic care management side, but also, how do I provide that access or appropriate access? So helping people navigate the system, I think, is what a lot of the community health centers are able to do.
Right, and I think the value of that, it's like what Dr. Grumbach said, right? You don't just say, I'm going to keep doing the fee-for-service model with 20-minute visits, and I'm just going to pay the docs more. So, are the CHCs, and you're right, with their encounter rates, right?
Yeah.
So are the CHCs an example of what you can do with primary care if it's adequately compensated? So you're sort of, and here's your return for spending more money on primary care, kind of a thought.
I would have to say yes, but but I'm kind of biased.
You are, I know.
Kim, you've had your hand up.
Oh, yes. So I love the community checkup. It's just like you said, it's just a vast treasure trove of information and things. It prompts all kinds of thoughts and wondering and anyway, my question is, how is it possible to start to move from even paying for value, to understanding and getting closer to paying for health? So do we have data that, I mean, I understand that the illness care system is not really the goal of the illness care system is to reduce illness, and to attend to illnesses, and stop the bleeding and all of that. But to get to health, and even fairly narrowly defined. I mean, not necessarily really expansively defined. Health and wellness and well-being and all manner. But like you were suggesting, which of course is wonderful. It's the dream. But even just health, thinking about actual stability and energy and sort of ability to function, level of function, and just like sort of fairly narrow bounds of definition of health. What do we know about the health that we're buying and where we're buying it, where we're buying more health and where we're spending a lot of money and not getting as much health? How do we understand that better?
God, that's a big question.
Yeah.
So I think what where you started with was really getting to sort of outcomes-based reporting, right?
Yes.
Because so much of the reports that we have are limited by a process, right? So it's a process that happened that we hope will relate to an outcome.
Absolutely, screening
And,
and testing and exactly.
and one way to start getting there is to be able to bring in clinical data, so data from an EMR, and we'll talk a little bit more with our board about being able to access that information or be able to produce that information. We see other states that don't have a claims database, but they have a clinical database, and so that one is limited because it doesn't have any claims, and it doesn't capture everything. It only captures, some of the clinical. So having the clinical could get us to things like, are we controlling blood pressure? Is that a measure of health?
A1C, and things like that.
It might be. Can we get, your diabetic, control? Yeah, you could probably get that. You can get that from claims if people submitted CPT2 claims. The whole claim system is actually designed around ICD-10 is around reporting and outcomes, and that's how the rest of the world uses it. We use it for reimbursement, but everyone else doesn't. So we have it limited. So our claims are limited to a reimbursement model versus a clinical reporting model. So there'd be a way to say, hey, we want people to. You can start it with, Medicaid or something else, but you can get people to complete CPT2 codes, report those codes, and then you can start seeing some of those measures. Am I controlling blood pressure? Am I doing this, that, and the other thing? I think we can measure sort of preventive services, again, a process measure in there. And then you get to some of the other questions, right? Well-being and
broader, yes.
Happiness and productivity and things like that. I think employers can do productivity pretty well. We used to measure that when I worked for a national insurer, so that we could actually measure a change. If they added, certain programs, could they get a change in productivity? And we did an initiative where we were looking at presenteeism, and so we applied a process to about 10,000 employees to do mindfulness training. They did an eight-week mindfulness training, and we're going like, I thought that was sort of foo-foo stuff. So I didn't think too much about it. But they asked people, how much of your work week are you just like spacing out and or goofing off or whatever? And people were honest and they answered it, which I was shocked. And then at the end, they asked the same people, well, how often are you goofing off or spacing out? And it improved by an hour a week. And when you think about that from an employer standpoint, an hour a week is hour a week times 10,000 people times their salary. That was like a big number. I can't do the math that fast, but so there's ways you can measure whether it's productivity or, but for a lot of people, it's I get to go to church, I get to go out to walk, I can walk around the block, so I think we'd have to come up with a rubric of how we would measure things, and how do you actually, how can you measure it in a way that's cost effective as well? Because, we've talked about, doing, patient, satisfaction reporting. That is really expensive, and the yield gets low. So are there other metrics that we can use to measure the health of a community? I think would be important. I see Elizabeth.
And I apologize, Elizabeth. We've passed our public comment period, so this period is only for cost board members for questions. Please feel free to submit your question in writing, and we can share that with Dr. Oliveira and see if we can get a response. Again, my apologies for.
Happy to.
Drew, thank you so much for being here. We appreciate you.
My pleasure. Thanks for having us.
Okay, we are now going to transition to the last presentation. And so I'm going to turn it over to Jen and Rochelle, and they are here to bring together the culminating of the two topics of focus, both consolidation aspects that we've been talking about in primary care, the implications for affordability. They also, I think, have some guiding questions for the board that will continue to inform the work moving forward and ultimately sort of the reporting at the end of this year that the board will do as well. So with that, I want to welcome two of our cost support staff members. Jim, Rochelle, thank you so much for the work that you do. Great to see you. And we will turn the floor to you.
Thank you, Director Moran. I think, why don't we start, if we can move ahead, Mary, to slide 4. We've seen a few of these slides before. So starting in the slide, this presentation will go into more detail on healthcare consolidation and primary care. And so the question is, why is consolidation of primary care practices occurring? So from the physician perspective, as the market becomes increasingly consolidated, the primary care practices that are still independent face increasing challenges with insurer negotiations and patient referrals. Physicians will often sell their practices out of a desire to enhance their ability to negotiate higher payment rates with insurers and to improve access to costly resources like technology, infrastructure, equipment, and facilities. They may also seek to reduce administrative and regulatory burdens and realize economies of scale. Next slide, please. The entities that consolidate with physician practices are potentially seeking increased profit, and some of the ways that profit may increase are through the ability to control the cost of care at the patient level, the ability to charge higher payments for certain physician services, leading to increased revenue, seeking to control Medicare Advantage dollars, and the ability to refer patients to in-system services such as specialists, lab, and imaging. Increased market shares lead to increased bargaining power with other market entities. Consolidation may make coordination across healthcare settings easier, and it may prevent practice closures, particularly in rural areas. Next slide, please. This slide has more detail explaining why Medicare Advantage may motivate consolidation with primary care practices, particularly on the part of insurers or corporate entities. The federal government pays upwards of $400 billion annually for Medicare Advantage beneficiaries. And then additionally, there are coding and risk scoring strategies, as well as performance on quality metrics, which may enable maximized payments. Primary care providers and practices manage the total cost of the Medicare Advantage care for their patients. And this makes acquisition of those primary care practices an attractive way for insurers and corporate entities to gain entry into the Medicare Advantage market. In the tiny print on the slide, there are a couple of examples of insurers and corporate chains that have entered the Medicare Advantage market, including CVS, Walgreens, Walmart, and Humana. And another example, Amazon acquired a large primary care group to create their One Medical program. In 2021, 5% of that program's members were in Medicare Advantage, and that small group of enrollees accounted for 50% of One Medical's revenue that year. Next slide, please. Primary care consolidation takes multiple forms. Next slide, please. Sorry. Physician practices may merge with each other. They may be acquired by corporate entities or insurers, such as the examples I just described. Hospital systems and private equity firms also acquire practices, and there can be arrangements with management service organizations and physician management companies. Next slide, please. And the slide has a few more examples of corporate-owned primary care practices. Next slide, please. So the next few slides are speak to the prevalence of primary care consolidation. This slide is an overview of healthcare consolidation at the state level across multiple markets. So this data is not specific to primary care. Just in summary, the Washington state insurance market is highly concentrated. 54% of Washington's hospitals are affiliated with a multi-hospital system, and 65% of all MDs and PAs, not just primary care, work in Washington hospitals. and private equity ownership has grown over the past decade. Next slide, please. This slide is specific to primary care. Nationally, close to half of primary care practices are now owned by hospitals. This was a rapid shift from just 14 years earlier when the percentage was 25%. Next slide, please. These maps are from an article published in JAMA last year. I know it's small and hard to see, so I'm just going to summarize what they're showing. For Washington, the greatest percentage of hospital and private equity affiliated PCPs occurs along the Puget Sound area and a little bit farther south, and that's the dark blue area on both maps. And this represents consolidation for 5% of the primary care market or greater. The orange color shows hospital consolidation and PE affiliation with PCPs that account for 2.5 to 5% of the market. And the light blue is 1% to 2.4%. The brown area represents no identified acquisitions, and we see that primarily in the central and eastern part of the state for PCPs affiliated with private equity. And again, this is all specific to primary care. Next slide, please. As mentioned earlier, insurer ownership of primary care practices is increasing and accounts for about 4.2% of the primary care market nationally. Optum accounts for 2.7% of that number. This slide includes some of the examples mentioned earlier with some additional data to provide detail on the size and scope of the acquisitions. A CVS Aetna primary care practice acquisition resulted in ownership of primary care centers in 200 locations, employing over 900 PCPs. Carleon Health was created with a merger between an insurer, formerly Anthem, and a primary care practice, and now operates primary care centers in 7 states. Next slide, please. And an article in Health Affairs described a 2023 study that found that the highest rate of insurer penetration in a large county nationally is in Snohomish County, Washington, where 45% of the primary care market is controlled by Optum. And then the rates are for other counties, 5 to 10% for all insurers in King and Skagit County, and 1 to 5% in Pierce and Whatcom counties. Next slide, please. And with that, I'm going to turn the presentation over to Rochelle Bogue.
Thanks, Jen. Hi, I'm Rochelle Bogue. I am the Cost and Transparency Manager, and I will get into primary care consolidation, risks, and benefits. Next slide, please. Okay, so the Stakeholder Advisory Committee met on February 19th. We had a panel that was comprised of a consumer rep, a hospital rep, a labor rep, an employer purchaser rep. And the stakeholders consistently described consolidation as something with both opportunities and consequences. There was a strong agreement that Washington needs more visibility into ownership structures and market trends. Panelists emphasized that policy solutions should focus on protecting patients, providers, and ensuring services, quality, innovation, and equity is not lost. And another recurring theme was that once consolidation does occur, it can be very difficult to reverse. Next slide. For consumers, what's at risk? Cost of care. Consumers often feel the impacts of consolidation most directly through costs and access. Even if care settings stay open, patients may experience narrow referral networks, higher out-of-pocket costs, or reduced continuity with their provider. The ability to easily navigate the healthcare system. And Stakeholder Committee also discussed how healthcare becomes harder to navigate when systems become larger, more complex. Next slide, please. For clinicians, what's at risk? One important theme was the impact on clinician autonomy and burnout. Many clinicians report that consolidation does not always reduce administrative burdens as expected. There are concerns about loss of decision-making, authority, productivity pressures, and reduced influence over patient operations when independent practices are consolidated. consolidated into larger networks. High turnover and burnout can also worsen workforce shortages and disrupt continuity of care and access for patients. Next slide. For employers, what's at risk? Employers are increasingly concerned about healthcare affordability and the sustainability of coverage. As the increase for healthcare premiums continue to significantly exceed wage growth and inflation, more costs are shifted to employees through deductibles, premiums, and cost sharing. Employers emphasize that affordability is no longer just a healthcare issue, it's also becoming a workforce competitiveness issue. Next slide. Consolidation's impact on healthcare affordability. Research consistently shows that consolidation is associated with higher prices. Hospital-owned and private equity-owned primary care practices tend to bill at higher rates than independent practices. Another important dynamic is site of care shifting. Services that were once delivered in lower cost community settings tend to move into higher cost hospital settings. And as you can see here, United Health pays Optum affiliated physicians 17 to 61% more than unaffiliated physicians. So this is just an example that illustrates how vertically integrated organizations may financially favor affiliated providers. Next slide. Possible benefits of primary care consolidation. So the stakeholder committee also acknowledged that there can be legitimate benefits to integration. For instance, larger organizations may be better positioned to invest in technology, care coordination, and multidisciplinary care teams. In rural or underserved communities, consolidation may help preserve clinics that might otherwise close. Next slide. Consolidation with retail organization impacts continuity of primary care. Retail and corporate models can rapidly expand access, but they may also create instability when business priorities shift. So here we'll see 3 examples nationally that show organizations entering the market aggressively and then scaling back or exiting after financial losses. So first example, Amazon purchased One Medical, a network of 240 primary care clinics in 20 plus US markets. Amazon acquired an MSO to provide One Medical's management functions. Amazon eliminated several hundred jobs supporting One Medical and pharmacy. In the second example, Walgreens became majority owner of primary care organization Village MD, expanding its provider network to 680 locations in 26 markets. Walgreens' parent company was acquired by a private equity firm. Walgreens sold 160 clinic locations after multi-billion-dollar losses. And then the third example, Walmart opened 51 health clinics in 5 states and closing all of them 5 years later. So that instability can disrupt patients' continuity of care, lead to loss of services and access in rural areas, as well as lead to issues with workforce retention. Next slide. Possible solutions. So the Healthcare Stakeholder Advisory Committee discussed a range of policy options that can strengthen oversight and accountability. There was interest in giving the state a more proactive role before consolidation occurs, rather than figuring out how to react after consolidation happens. Another recurring theme was that policy approaches need to support affordability while preserving access and innovation. Next slide. And then, as Judy mentioned, the Primary Care Advisory Committee met on April 23rd. And this is just a quick summary of that discussion that took place on market consolidation. The Primary Care Advisory Committee echoed many of the same concerns that the Stakeholder Advisory Committee identified. Price growth and reduced competition in consolidated markets were major themes. There were also concerns about loss of services, particularly when acquisitions involved faith-based organizations. At the same time, primary care members did acknowledge that integrated systems can improve coordination and support more team-based care delivery. And the central question and key takeaway, as Judy highlighted in her report out, was whether market oversight can preserve the benefits of consolidation while also mitigating the risks. Next slide. This here is the NASHB model to address consolidation. So you'll see it split into two different colors. Orange is limiting the behavior of already consolidated systems. And so Washington does fall into that category. However, we're not 100% consolidated. So the green category prevent further consolidation is also applicable as well. So NASHB's framework emphasizes building state capacity to proactively monitor and respond to consolidation. The model highlights that states need stronger data infrastructure, clearer authority, and ongoing monitoring, not just one-time transaction reviews. It also reinforces that affordability, access, and workforce impacts should all be considered together when evaluating transactions. Next slide. What are other states doing? A growing number of states are adopting more active oversight strategies, and those include transaction review laws, cost growth benchmarks, primary care spend targets. Oregon is often highlighted as a leader in this realm because it has authority to not only review transactions, but to place conditions to mitigate risks or even stop transactions altogether. And as we heard during Oregon's transaction review presentation at the March cost board meeting, their review process also considers impact on cost, access, and equity. Next slide. How do transaction review laws help primary care? Transaction review laws can provide earlier visibility into consolidation trends before market impacts occur. So this goes back to one of the themes that the stakeholder advisory committee members identified about being proactive rather than reactive. They may also help preserve independent practices by limiting outside influence over clinical decision-making. Another important function is increasing transparency around ownership and financial arrangements. And these laws can help states evaluate how transactions may help affect affordability, workforce stability, and access to care. Next slide. And I think this is the last slide. So we talked about all of the different trends that we're seeing here in Washington, what other states are doing, and this slide leaves us on a high note. So opportunities for Washington to mitigate impact of primary care consolidation. Align, improve, and evaluate. So align. One opportunity is aligning market oversight efforts more directly with Washington's primary care goals. That would mean considering affordability, workforce, and access impacts during transaction reviews. Improve. Stakeholders emphasize the need for better data and transparency. Tracking ownership trends and site of care shifts could help identify concerning market changes earlier or before they happen. Analyzing price variation by ownership type may also help clarify where affordability impacts are changing. And finally, evaluate. There's a need for ongoing evaluation after consolidation, especially in a state like Washington that's already very consolidated. That would include monitoring impacts on rural access, workforce pipelines, quality outcomes, and service availability over time. So the goal is not to simply track transactions, but to understand whether consolidation is having negative impacts on Washington's healthcare system, affordability, and access to care for Washington residents. And that's the end of the presentation.
Thank you, Rochelle. Thank you, Jen. A lot to take in there.
Yeah.
Questions from the board or comments? Go ahead, Emily. Yeah.
just so you've got something to work with, Rochelle and Jen. So thank you for this presentation. It's really interesting, and I think there's a lot to digest here. One of the things that I'm pulling forward from our earlier conversation and into this conversation is this relationship between the need to invest in some areas of the health sector, primary care, for example, and the need for guardrails as we consider any investments or kind of cash infusions into areas of the health of our health system. So I think we were talking earlier with Dr. Grumbeck about what are those guardrails? What are some of those safeguards? And I think this presentation gives us a sense of that, which is if we are going to, for example, invest in primary care, how do we make sure that we have oversight into the ownership structures and the incentives that are that will be present there, and then make sure that we have, again, payment policies that consider things like site neutral payments, so that we're not creating some of the same structures that recreating some of the same structures that we're seeing in the system today. So that's maybe just a reflection on all of the different pieces of our conversation today and how they fit together. And I see Kim has a hand up, so go ahead.
Yes, hi. I'm intrigued by the comments about the benefits and the advantages, opportunities that come with consolidation. And also putting that together with what I think, that Oregon was sharing with us about the kind of engagement, I think, around consolidation that they're able to have, or that's what I recall. Specifically, I'm thinking of, proactive intervention, so to speak, that might be something like, negotiating essentially. I think maybe you were implying that, Emily, that, whether the consolidation has already occurred or whether it is being contemplated, and the state is alert to it, it seems that there are opportunities to step forward and say, hey, we need to talk, and we understand that, there are hopes and motivations and goals, that the organization, the business entity is out after. And we have those types of hopes and goals and needs as well. And so, I think, I want to believe there's an opportunity, to share forthrightly and to negotiate how to formally, get commitments to what is going to be attempted and what is going to be measured and tracked and who's going to be accountable for what. So business can win, in some ways that they, it's meaningful to them. And I don't mean to use us and them language. I don't mean that. I actually, the contrary, I'm trying to say there is a way to do right and do well. Potentially we should be looking for places to do that. We also need the guardrails, the safeguards, and all that stuff. I'm not, in Pollyanna land. I mean, you don't have to, but anyway, so I want to say I am intrigued by that, about being proactive together and being just really open and forthright about what we must be, what we must accomplish, and what we must create together, the state of affairs about healthcare in Washington. Thank you.
Leah?
Thank you. Actually, I was just gonna maybe piggyback off of Kim for there might be some learnings from L&I's collaborative care model where there are higher essentially encounter payments and payments for outcomes, which is really similar to the advanced primary care concepts that HCA has led. So when we think about guardrails or payment system reforms. Maybe there's some lessons learned from that one, which is, has decade or so of experience at this point, and I haven't heard that it has been exploited in some of the ways that we've heard to date. So I don't know if there's any learnings that we can pull out of some of the UW studies or something else on that model.
Yeah, appreciate that mention, Leah. Yeah, Jane.
So thanks so much for all of this thoughtful work. The one theme that I would suggest in terms of opportunities is around purchasing strategies. So as we've had discussions in the legislature over the past couple of years, I think we, the Office of the Insurance Commissioner, the Healthcare Authority, have tried to think about where there are policy initiatives that the state could take that would cross Medicaid, PEPSEB, and the commercial health insurance market. When you pull those three in, you're talking about 3.5 million people. And we know what works in primary care. Drew did a great job, and I think staff did too, about the value of effective primary care. And it seems that a more direct approach might be to use a purchasing approach to drive the changes that you want to see in primary care delivery. And I think we're seeing some of the large employers, self-funded health plans who have already figured this out, and they're doing some direct primary care contracting. And so I think it would be a great discussion with the Washington Health Alliance to sort of get a sense of where are the large self-funded employers in terms of their purchasing strategies around primary care, and are there opportunities for alignment there as well. So yes, exploring regulatory themes, but also exploring purchasing opportunities.
Well said. Art?
I couldn't decide whether to ask a question because I still feel so new, and I feel like I'm going to ask questions that people are going to say, "Oh, that was asked months ago." But on the consolidation, I mean, one of the benefits of consolidation, and I'm not saying consolidation is definitely good, is just survival. I mean, if you're a small clinic and you can't, what do we hear today? 40% increase in B&O tax and so on. It's not necessarily a PC firm buying a revenue stream. Sometimes it is firms consolidating because if they don't have the scale, they can't exist. And so I guess I'm thinking when I hear guardrails and everything, what about the issues that may need to be addressed prior to the guardrail conversation? I'll stop there. It's a can of worms, and I worry that as an economist, I think about things a little bit differently. I know at home, my wife's a physician, and we definitely ask different questions. But
thank you, Professor Hodges. I'll respond quickly to that. We really liked that NASHB model that Jen and Rochelle showed that kind of looks at the current situation as it is, acknowledging that many markets are already consolidated or highly consolidated, and kind of encourages states to take an approach of tailoring it to the existing market. So that would speak to, asking the state to identify their goal of, your market's already consolidated. What issues are you trying to address? And I think that in some ways gets to, I think what you're hinting at of the underlying cause, and we certainly heard that from commenters as well, that, market oversight does address some of the downstream effects, but is it really getting at that root cause? And so I think we found a lot of, opportunity with that NASHB model that would allow us to sort of tailor it to not only Washington, but Washington as it is right now is a highly consolidated market. So would love to know if you have any thoughts on that. And that's certainly a model that we're looking to explore further.
No, I'm going to follow up with you offline and talk to some of the staff to make sure I'm up to speed on where the group is. But I mean, I'm familiar with the Ashby model and do want to dig in more. So.
And you asked a great question too. Someone that was here for a year wouldn't have asked as good of a question. So thank you. Yeah, go ahead, Emma.
I'll just say very briefly, I think it is a smart question, Hart, and thank you for raising it. And I think it gets a little bit back to what Jane was raising about the purchasing strategy. Because one of the things that we've often heard from provider groups is that they feel driven to consolidate because they're dealing with 17 different quality metrics, 10 different other measures that they need to meet, and a million different value-based payment strategies. And they're trying, but they're struggling under the administrative weight of that, right? And so they say, well, maybe if I can buddy up with a bigger entity, they'll help me manage all of that. And I think we need to acknowledge that pressure. And one of the things that purchasers can do is to get together a little bit more and to say, okay, here's what we expect in terms of quality, here's what we expect in terms of ability and other metrics. And let's take some of the weight off of those competing demands from purchasers. So I think it makes sense what Jane is saying to think carefully about the consolidation strategies, making sure there are those safeguards, and also think about purchasing strategies that help providers stay afloat in a streamlined fashion.
Combine the ideas and simplify some of the admin.
Right? Yeah.
Yeah, exactly. I appreciate you also bringing that into the room, Hart. And I think both of the buckets, like on the Nashville model, I think one of the things even in the second bucket of preventing the further consolidation and some autonomy for states to look into those transactions on the front end, if you will, does allow for some of those underlying reasons come to the forefront. And one would hope, right, would yield itself to other policy ideas of prevention of the situation that you just described too. So I think it fits in both areas. Any other comments or questions? Jen, Rochelle, we're grateful for your work and your expertise. Thank you so much for being here. I think one of the things I will note for the board, as we look to close out this particular discussion, is today was topics a little bit deeper on sort of the primary care. How does that meld with the consolidation pieces? I think at the next meeting that we will prepare for, which is July, staff and team will look to take your insights, feedback, et cetera, from today and go a little bit further towards the path of the market oversight policy strategies that would be considered as the state were to move forward, and to likely come back and get some reactions from the board on a little bit tighter details of what those possibly could be in advance of the opportunity for us to set board recommendations by the end of the year. So I think we can prepare for that conversation, I think, in July. Yes. Hold me honest on that topic. But I think from what we heard in March to what we hear now, stage is sort of set for sort of the next layer of that. And obviously, subcommittees doing their work too. Are there any other comments, thoughts, or questions from the board for today's meeting before we look to close out? Okay. Well, hearing none, again, as I noted, the next meeting is July 22nd, 2 to 5. We will look forward to seeing you there at the peak of summer. And the summary of this meeting will be posted on the website along with the recording for those in the public. For members of the public that were not available for public comment, we absolutely do want to hear your voice. And so there's opportunities to bring your feedback directly to the cost board and staff that are associated with the cost board at HCA. So we welcome your contributions and your input to that and to respond to your questions. Board, thanks so much. Yeah.
Point of personal.
Yeah.
To thank Jane Meyer for
Oh.
participation on this cost board service. Develop this work. This is her last meeting with us.
I just want to say I'm in denial about Jane's departures as I've been having these conversations. Thank you, Michelle, for that point of privilege. Yes, thank you so much. And I would One of the treats this week was I would encourage all the cost board members to listen to the interview and the podcast that you did with Commissioner Kruger and your years of service to the state and your years of service to the healthcare community. I think people will walk away realizing that your mark was made. It was really compelling. So we will miss you. Yes, Eileen?
I would just say she's not really leaving.
Yeah.
I may be in total denial, but she's not going to draw. I know Jane well enough. She is not going to totally disappear.
I have said that I will still have my hands in health policy, but at the same time, I'll have my granddaughter in my arms.
Okay, that's fair. But you're as bad as I am. You're not totally disappearing.
Well, Eileen, I was just going to say, do you think Jane's learning from you in this regard? What happens next? So, yeah. All right. Thank you, Jane. We will miss you. We will absolutely miss you. And we will be joined, I think, by Ingrid Ulrey.
Yes.
Yes.
So Ingrid Ulrey had started as my successor as Senior Health Policy Advisor to the Commissioner. And she started on May 18th. So we have the luxury of having a few weeks of overlap.
Great.
And she will be wonderful to work with. I mean, she has a long history in health policy, a long history in Washington State, and she and the Commissioner are getting along incredibly well. So
good.
Yes.
And the great thing about Ingrid in that particular position is since she was just on the exchange, she was on
Yes.
the cost board, so she knows this work.
Yeah.
So seamless transition.
Yes.
So you rock that one too. All right, everyone. Thank you so much. Take care.
Thank you, Michelle.
Thank you.
Meeting adjourned. Thank you all.
Thank you, Michelle, for the very